Good morning, everyone. My name is Mike Lebsack. I'm the Director of Cardiovascular Services at Mercy. I've been here about 24 years, and tell you a little bit about our presentation today. First thing is I'm always pleased to share Mercy's mission. We're a community hospital, Catholic hospital, and our mission is to heal and comfort the sick and then work to improve the health of our community. And to carry out the first part of our mission, we work in partnership with our talented medical staff. And to carry out the second part of our mission, we work with organizations and community initiatives like the Blue Zones that you folks have been hearing about to further everyone's health. Being with you today and talking about our cholesterol is just one way to carry out that mission. Let me tell you a little bit about Dr. Mehegan. I've worked with Dr. Mehegan almost 20 years, right? Would it be? Okay. He's a cardiologist, and he's been a member of the Iowa City Heart Center since 1994. He attended medical school at the Ohio State University. He did a residency in internal medicine at Bethesda Naval Hospital and a cardiology residency at the University of Iowa. Dr. Mehegan is board certified in internal medicine as well. He's also the director of our cardiovascular rehabilitation program. So with that, let me join you folks in welcoming Dr. Mehegan. Thank you.
Good morning. I don't think you'll have trouble hearing my voice. I don't imagine you'll have trouble hearing my voice. I grew up in New Hampshire. This is Winnipesaukee, New Hampshire. My family home is in Sunapee. I lived there for 13 years. I went to Montreal to school for college, an undergraduate education that was $600 a year. It's changed a little since then. I went back to Ohio, which was my family home, and went to Ohio State. I was there for 4 years. It was a 3-year medical school. I did 1 year of cardiovascular research. I did 1 year waiting tables as well. I'm a very good waiter, just to let you know. And then from there, Bethesda Naval Hospital, you guys paid for medical school, and I served 6 years in the Navy, 3 years training at Bethesda, 1 year on a ship, and 2 years on staff at Bethesda. I came back here, followed my wife, who's a professor of biochemistry at the university. I told her where I would live and where I wouldn't live, and the Midwest was okay. I wasn't going to live in Boston, and I wasn't going to live in Los Angeles. And we've been here for 23 years, which is the longest I've lived anywhere. So I'm truly an Iowan, but we'll go east on occasion. That is a view from my front porch. And the topic is cholesterol and its role in the atherosclerosis, hardening of the arteries, coronary disease, stroke, etc., goals of therapy. Again, my emphasis, is the issues regarding prevention of cardiac disease. That's what I'm going to discuss. And I'm going to discuss sort of the hard evidence that's available for the therapies that I advocate, more than I will discuss issues regarding non-medical therapies. This will be a medical therapy emphasis just because that is my emphasis. We'll discuss the different types of cholesterol. We'll identify cholesterol levels that are available and provide an overview on medications used for treatment. Cholesterol is just a serum fat. It's a universal product. It's in every cell in the body. It's an essential component of the cell wall. Without cholesterol, without circulating cholesterol, obviously you aren't alive. So it is absolutely necessary. But it'll also become clear that cholesterol levels have to do with the development of pathologic processes, and I'll discuss that. It comes from two sources. About 80 to 85% of your circulating cholesterol is produced in your liver, so you make it. And again, you have to make it. If you don't make it, you will not be alive. Somewhere between 15 and 25% of your circulating cholesterol comes from the things you eat. Again, the sources of food, cholesterol, you know about. They come from meats. They come from animals. These are not a source, or these are not a vegetable product. Again, it is essential for the formation of all cells. It's essential for making bile acids that are used to digest foods. All of your circulating hormones are composed, or at least a component of, cholesterol. It causes atherosclerosis. That's a nice way of saying hardening of the arteries. That's a nice way of saying plaque development. That's a nice way of saying the substrate by which stroke, heart attack, and death occur. Aging causes arteries to harden. Cholesterol is one component of that process. Cholesterol goes into the cell wall and becomes what we call plaque. Basically, it causes stroke, heart attack, death, peripheral vascular disease, all of the manifestations, all of the things that I treat. Cholesterol is one of the essential components for developing plaque. There are good cholesterols and bad cholesterols. LDL is the bad cholesterol, and again, the most the information we have about atherosclerosis, development of coronary disease is LDL related. HDL is the transport molecule. It carries cholesterol away from the cell. And I'll discuss that role. Triglycerides are another serum fat. Again, the direct relationship, direct role is not as clear. Triglycerides are associated with many other things, including diabetes. Certainly they have a component, but the direct relationships are not at all as clear. What is more important? The answer is they're all important. Every one of them is important. We certainly have more information about LDL, LDL manipulation, the effects of LDL on the development and the treatment of LDL in progression of coronary disease. LDL is the bad one. It contributes to the development of plaque. And again, plaque development obstructs arterial blood flow. That's what it does. It obstructs the flow to the artery. In its chronic manifestations, these are things of angina, tightness, pressure, squeezing, heaviness, problems with peripheral vascular disease or claudication, the legs giving out. In its acute manifestations, these plaques will rupture, the artery will close, and the end organ involved will lose its blood supply. That's a heart attack. You want the LDL to be low, diet, exercise, medications. LDL is not necessarily something you can strictly manipulate. You know, if you exercised for, 600 hours a day, it's not going to make your LDL go away. And if you've got a baseline LDL of 300, and you diet, it'll go down 15%. But if you become a vegetarian, it will not make your LDL cholesterol 120. That's just the way. When you diet, you'll be able to reduce your LDL cholesterol somewhere between 15 and 20%. If you become a vegetarian, that's about the max in terms of reductions in LDL cholesterol. So again, this relationship between LDL and the development of coronary disease is well established. And if you look across the bottom, doubling your LDL cholesterol from 91 to 168 or 90 to 180 basically triples your cardiovascular risk. This epidemiologic relationship, this relationship between your LDL cholesterol and cardiac events is well established. We know this is true, which is not to say causative. That means because the LDL is higher doesn't mean it causes atherosclerosis. But as it turns out, the inverse relationship where we manipulate LDL, lowering LDL, eliminating cardiac events, that is also well established. And so again, this relationship is clear. We do know that LDL does contribute to and is causative. We also know the inverse, that if we lower it, we reduce cardiac risk. This is the population of patients having a heart attack. And again, if you look at the majority of patients having a heart attack, their LDL cholesterol is normal. That's the fact. LDL is somewhere between 90 and 130, 140. It's within normal range. Again, the majority of people who are having a heart attack don't have high cholesterol values. That's just the fact. So LDL is just one component. The other components are all things that you know about. Age. You can't do anything about age. And again, my line is lead a perfect life and I'll see you when you're 80. You don't necessarily get out of life without cardiac events occurring. Hypertension, diabetes, smoking, all of these are contributors, but understand the process of atherosclerosis is extraordinarily complicated. We understand fairly simple aspects. We don't understand most aspects. And what's going to happen in the next 10 to 20 years is in the realm of biochemistry, molecular mechanisms dealing with what the actual causes are, manipulating those causes, and trying to put cardiologists out of business. So that's what my wife is working on. That's what biochemists are working on. Now, she has not succeeded and won't succeed in the next 10 years. So I'm secure that I'm going to have a job for the next 10 years. People have been trying to put me out of business for a long time. And again, you'll see that even I am trying to put myself out of business in a sense. HDL is the transport molecule that carries cholesterol away from the cells. The higher it is, the better. Again, the epidemiologic relationship is very clear. Manipulating this molecule is less clear. If you look at, again, you know of no specific HDL, well, that's not true. There's one, niacin. But of all the billions of dollars spent on HDL-raising drugs, most of them have failed. That is, proven effective drugs raising HDL cholesterol that did not necessarily result in a better outcome. So manipulation of this is less clear. The epidemiologic relations are also clear. For populations where there is a higher HDL cholesterol, there's a lower incidence of cardiac events. And again, there is some relationship between alcohol consumption, that is, in Mediterranean populations, wine drinking, the incidence of coronary disease is less. The incidence of alcoholism is higher. And again, alcohol is what it is. When you look at, there is a relationship between moderate alcohol consumption and cardiac events. So if you like wine, have a glass of wine, not 22 glasses of wine. What you really wanted to do was have better parents, because most of this is genetic. You are delivered an HDL cholesterol. And if your HDL cholesterol is 18 or 19, call your parents because they gave you a bad card. And really, there's not a lot you can do about it. It is one of the causes of premature atherosclerosis. It's one over which I have less control and less ability to manipulate. Triglycerides, again, this is a serum fuel. That's what it is. It is burned by exercise. It's burned by things that you could do. It's worsened by sedentary lifestyle, carbohydrate consumption. Poor diabetic control is associated with high triglycerides. The relationship between triglycerides and coronary events is real, but it may have to do with other things rather than just triglycerides. And manipulating triglycerides, the evidence is less clear than it is for LDL. Again, these targets, what is good? What is a good cholesterol? Understand that most of this is a group of guys sitting around the dining room table. That's what it is. The science is not real. It's people that sitting there saying, oh, I think 200. Yeah, okay, that's good. Let's say 200. There is some science to the LDL numbers, particularly when you look at studies that have looked at comparative outcomes. We set an LDL of 70 for patients who have had an event, that is recent events, and that's based on studies that looked at people treated to LDLs of 100 or people who treated to an LDL of 70. Those treated to an LDL of 70 had 20% fewer events than those treated to an LDL of 100. For people with stable vascular disease, that is established vascular disease, our LDL target is 100. For people with risk factors, it's 130, and for everybody else, it's 160, maybe. There's a lot less information or evidence. Those are our current targets. Understand that people are looking at these targets. And again, when you look at your multi-billion-dollar Crestor, they would love to prove that LDLs of 40 or better, and they're looking at large populations of patients to see what's going on. That's Squam Lake, so that's on Golden Pond. There's a little trail that you walk up. It's one of the easiest trails I've ever hiked. But you get to this view overlooking at Squam Lake, and in the background, it's Winnipesaukee. The interesting thing about Squam Lake is it's about 30% protected. That is, the shoreline is undeveloped for 30% of that lake. All right, goals of therapy. Again, the goal of therapy is not LDL lowering. The goal of therapy is not making numbers better. The goal of therapy is doing what I call preventing the big three: stroke, heart attack, or death. That is the true goal of therapy. It is not when you emphasize numbers, what you're trying to do is sell a drug. When you emphasize stroke, heart attack, or death, what you're trying to do is prevent cardiac disease. The FDA will release a drug based on numbers. That is, there are cholesterol-lowering agents released that lower LDL but don't have any outcome data. That is, no data that shows improvements in stroke, heart attack, or death. That's obviously not true for several of the things I'm going to talk about. Pooling endpoints. Again, when you look at trying to prevent events, trying to prevent a heart attack, again, you can arrive at statistically significant information a lot easier if you pool the endpoints. Put together hospitalizations for coronary disease, heart attacks, unstable angina. You'll get a lot more patients in the pool. You'll arrive at a lot better statistical inferences by pooling the information. But again, individual endpoints is what you'd love to have, but the fact of the matter is, it's harder to get that. It's statistically much harder to get an individual endpoint of death than it is when you gather it in with a whole bunch of things, and that's how these studies are done. They are done by pooling endpoints. And again, what does it cost? When you run an outcome trial, what does it cost? Well, there's an ongoing trial looking at Zetia and Zocor versus Zocor alone, 20,000 patients, 5-year follow-up. That cost is somewhere between $500 and $1 billion to run the trial. That's what it costs to run an outcome data where they're expecting about a 20% reduction in a pooled endpoint. Now, again, and you'll see that what happens is that statistics are much better if the incidence of disease in the population is high. That is, for people with known or established coronary disease, it's much easier to arrive at a statistical endpoint than it is for people with a low incidence of disease. If you did studies of cholesterol-lowering therapy on 18-year-olds, you would never arrive at a conclusion saying there's a benefit, period. Because the incidence of coronary disease in that population is so low, you'd never be able to prove that therapy was a benefit. If you take that same study looking at 75-year-olds who have had a previous heart attack, you'd be able to study 2,000 and be able to arrive at statistical information within 2 or 3 years proving a benefit. What about diet, health foods, red rice yeast? What about garlic? What about understand that the information will never be available? There will never be, unless the federal government studies it, because nobody's got $500 million to spend to prove that a specific diet, a specific health food agent, red rice yeast, or anything will result in a better outcome. There'll never be statistically important information that proves the benefit because nobody's going to do the trial. Does that mean they are not beneficial? The answer to that would be absolutely no. Does that mean I'll ever be able to tell you about garlic? The answer to that is no. I'll never be able to tell you about garlic. Can't. And so when these things are sold as cardiac protective, they're allowed to do that because they don't require proof. These nutritional agents are not required to present proof. They can make a statement, but they don't have to prove it. For a drug to make the same statement that we result, they have to prove it. But these do not. That's just the nature of the beast. So I can't give you information. I can talk to you about medications. And again, I put statins at the top of the list because most information is available. Statins are by no means the first of these agents that were produced. Statins were developed somewhere around 40 years ago. But the first thing that was available were bile acid binding agents. Niacin is a vitamin, and I'll talk about all these others in sequence. All right, statins. Statins are the primary therapy for prevention of cardiovascular disease in the cardiology population. There are 6 statins that you see up there. There's actually a 7th statin out there that was just released in the last 2 years, whose name I don't know, and I don't know where it would fit. Why? There are 6 generic statins and 1 non-generic statin. When you look at the hierarchy of strength of the statin, Crestor is the strongest member of the statin class. Crestor is also the only one that's not generic. So if you go to buy Crestor, you're talking about somewhere between $100 and $140 a month. All the other statins are generic. And again, the next in strength is Lipitor, then Zocor, then Lescol, Pravachol, Mevacor, all sort of grouped around the bottom. If you look at the effect of these drugs, Crestor results in somewhere between a 40 and 50% reduction in LDL cholesterol. So it'll reduce LDL cholesterol by 50%. Lipitor somewhere between 30 and 40%. Zocor, simvastatin, somewhere between 25 and 35%. All right. Statins are generally well tolerated. If you look at populations in whom statin, and again, that's why these are drugs that are preferred because they're easy to take once a day. Now they're cheap. They didn't used to be cheap. And generally, they are well tolerated. For most people, you can take them and they don't have a lot of side effects. Somewhere between 5 and 10% of people are statin intolerant. They cannot take them for various reasons. Again, the majority of that is muscle problems or muscle pains. The dreaded complication is rhabdomyolysis. Now, we live in Iowa. If you guys read the newspaper, you know the Iowa football team got rhabdomyolysis about a year and a half ago, because of weightlifting causing muscle to break down. Again, the dreaded complication of statins is rhabdomyolysis. The incidence is around 1 in 100,000 to 1 in 200,000, but again, the incidence is increased when you combine therapies. It's also affected by which type of statin you use. It's also affected by the dose of the statin you use. It is a dose-dependent effect. I have seen rhabdomyolysis occur. about 4 times over the last 23 years. And the original episodes were Baycol. Baycol was a very strong statin, probably stronger than any of the ones we now have. But the problem was people were combining it with other drugs. They used Baycol and another drug, and there were thousands of cases of rhabdomyolysis across the country. Baycol's gone. The drug was too strong, and when you combine it with other therapies, it's gone. I've seen it occur in one other patient, an 80-year-old man who was on 80 milligrams of simvastatin. And again, he was on high-dose simvastatin. We don't prescribe as initial therapy 80 milligrams of simvastatin for anybody anymore because of this interaction. Liver tests, for all the years people have talked to me, well, what about my liver? What about my liver? Well, the fact of the matter is the incidence of liver disease is extremely rare. Developing liver disease with these drugs is extremely rare. The FDA says you don't need to monitor liver tests anymore. That's new in the last year, so we don't do it. These are over-the-counter drugs in Europe. That is, simvastatin is bought over-the-counter in Europe. And there are several reasons. One is safety, and the answer is if it's over-the-counter, the government doesn't have to pay for it. What about cancer? What about dementia? The answer is there is no proven benefit or established harm associated with any of these drugs in thousands of patients. So it didn't work at preventing dementia. Would have been nice. It didn't work at causing dementia. And again, there is no established cancer relationship between these drugs. And I'm going to just talk about glucose. There is a relationship between the use of statins and glucose. And again, if you look at relative risk, again, it is somewhere around 1.1 to 1.2. So glucose levels can go up when you use statins. That's a fact. So again, for people that have this tendency towards diabetes, you got to monitor their glucose and see what happens. You're always doing a risk-benefit analysis, but in each study, in each of these studies, except for the top one, there was some increased risk in the development of diabetes for patients on a statin. That's a fact. I'm not sure why. I'm not sure why. Primary prevention, secondary prevention. Primary prevention is preventing the first event. That is, people who have not got established cardiac or vascular disease. People who come because their mother had a heart attack at the age of 50 or they're a smoker and they want to know what their risk is and they're trying to prevent their first heart attack. What I do is secondary prevention. Again, secondary prevention is preventing cardiac disease in people with established vascular disease. So see people who have had a heart attack, or people who've had a stroke, or people who've had bypass surgery, or angioplasties, or stents, or unstable angina, or peripheral vascular disease, and even diabetics are probably regarded as secondary prevention. Understand the difference between primary prevention and secondary prevention is the incidence of events. There are going to be a lot fewer heart attacks in people in a general population, a lot more heart attacks in people who've already had a heart attack. That's just a fact. So again, it's much easier to prove the benefit of a trial, if you're treating a group that has already established disease. These are all randomized trials. These are all trials of somewhere between 3,000 and 5,000 patients. West of Scotland was middle-aged men with risk factors, no women included in the trial. These were men that were hypertensive as smokers. They had LDLs of 150 to 160, 26% fewer heart attacks, no survival benefit. And I'm going to show you a slide on text caps. This was a Texas primary prevention trial. Ascot was Lipitor, and Lipitor was used in a group at high risk. They had combined risk factors. They also had hypertension with EKG changes. And again, Ascot resulted in a survival benefit for the use of Lipitor in a high-risk population. I'm going to show you Jupiter. Jupiter was a trial of C-reactive protein. One of the components of atherosclerosis is inflammation. Inflammation causes arteries to develop plaque, and Jupiter trial was a trial. Secondary prevention, again, in the 1970s or 80s, they took 4,444 Scandinavian men and women with coronary disease. That's the simvastatin survival study. There were 1/3 fewer strokes, 1/3 fewer heart attacks, 1/3 fewer deaths, each statistically significant in 4,000 patients with established vascular disease versus placebo. I'm going to show you a heart protection slide, and Prove It is the only head-to-head trial between two statins, Lipitor versus Pravastatin. Pravastatin was losing their market share, Pravachol was losing their market share, and they wanted to prove that it was just the statin. That is, all you needed to be was on a statin, and it didn't matter which one, and they lost. Pravastatin resulted in an LDL of 100. Lipitor resulted in an LDL of 70. There were 20% fewer patients who had an event on Lipitor. So that is the only head-to-head trial between statins. Again, what they proved was that in that very high-risk patients, lower was better. So 70 was better than 100 in that very high-risk group. So they did prove it, but they didn't prove what they wanted. They proved that lower was better. This is, again, putting myself out of business. Unstable angina, fatal and non-fatal MI, sudden cardiac events. This is a primary prevention trial. You can see that the numbers were 3,000, it's about 6,000 patients randomized. These were patients on lovastatin, and the year of the trial was 1998. So this is a long time ago, establishing in a group of patients who did have combined risk factors, more than one risk factor. Again, the risk factors are smoking, diabetes, family history of premature coronary disease, age greater than 65. And again, a 37% risk reduction in primary prevention trial. This was not a survival study. They didn't show a survival benefit. This is the Jupiter trial. Again, the C-reactive protein. There is a relationship between inflammation and cardiac events. And again, this was a specific trial looking at patients with normal cholesterol values, but an elevated C-reactive protein. So they're looking at people who are at risk for cardiac events, who had a C-reactive protein suggesting cardiac inflammation, using 20 of Crestor. And there were 47% fewer events. Myocardial infarction, stroke, death, revascularization procedures. Again, this was a primary prevention trial in people whose primary risk factors established were an elevated C-reactive protein. So, should C-reactive proteins be measured? Good question. All right, simvastatin survival study. Again, who derived a benefit? Who derived a benefit from therapy? Doc, do I really need to take my cholesterol pill? Well, men, women, older, smoker, hypertension, diabetes. I'm 85. Do I really need to take a statin? As it turns out, the event is what puts you at risk. Your age has nothing to do with it at all. All I'm trying to do is prevent an event in the next 5 years. That's all I'm trying to do. And I'll take my 5-year increments and then go another 5 years beyond that. But again, no matter what your age, no matter who you are, no matter what your risk factors were, it was about a 30 to 40% risk reduction in terms of events, higher for those in diabetes. This is a secondary prevention trial. And again, what about if my cholesterol values are normal? This is the heart protection study. Again, what they're looking at is treating everybody. They didn't even measure cholesterol values. All they did was put them on Zocor and follow them. So randomized 20,000 patients to see who derived a benefit. And the answer is everybody. Cholesterol is less than 100, LDL is less than 100, 129, 130. Again, when you look at relative risk reduction, it's all the same. So if your cholesterol values are normal, we still treat you with statins. That's the goal of therapy. And understand, in the realm of scorecard medicine, Medicare looks at my use of statins in patients with established disease. Blue Cross Blue Shield looks at my use of statins and grades me according to how much I use it. And if you think I'm joking, I'm not. I receive a scorecard. It'll be published in the newspaper in the next 10 years. My score will be published in the newspaper. You'll be able to read it. You'll know how many patients I am treating with a statin. It will be published in the newspaper. I guarantee it. It'll also look at my mortality associated with cardiac events. It'll look at a whole host of things, but it'll all be published. Bile acid binding resonance. So we're moving beyond statins, and we're going to talk about the other stuff. Statins are the primary role of therapy, but there are 5 to 10% of people who can't take statins. So we try other things. These have been used for a long, long time. The bile acid binding resonance have been used. Cholestyramine, Questran. The problem is they're hard to use. They cause a lot of stomach side effects, constipation, nausea. It's kind of like drinking sand. People don't like taking it. They're hard to use. These are older than the statins. They will lower LDL cholesterol somewhere between 15 and 20%. And again, as such, will reduce cardiac risk for people with established cardiac disease by about the same amount. So we do use them as secondary therapy. Niacin has been around for 40 years. And the problem with niacin was always this problem with universal flushing. It does everything right. Raises HDL, lowers LDL, lowers triglycerides, but it causes all of these sort of side effects. And again, when I started using it 25 years ago, before these delayed release or slow release preparations, I got about 1 person out of 1,000 to take it, just because you didn't like the side effects. For people that are statin intolerant, we will use niacin. One of the things that isn't mentioned in there is that niacin will raise glucose a moderate amount. The fibrates, gemfibrozole has been around for a long, long time. Tricor, fenofibrate, benzofibrate. They lower triglycerides, raise HDL, don't do much to LDL. They don't affect LDL very much. There are certainly trials that have looked at the use of fibric acid patients as primary therapy. That is, people who were not taking a statin and had as their primary problem a low HDL. These are proven effective drugs at preventing cardiac events. Again, they are not primary therapy. And then this is Zetia. Zetia blocks cholesterol absorption. And I mentioned at the beginning, drugs are released that lowered LDL cholesterol that don't have any proven outcome benefit. This is it. There is no survival study. There's no outcome study. There's no stroke, heart attack, or death study that looks at the use of Zetia yet. The combined Zetia-Zocor versus Zocor trial is a 20,000 patient ongoing, completed in 2012, published in 2013, and I haven't heard anything yet. Omicor, fish oil. Fish oil lowers triglycerides. And again, as primary therapy, these are adjunctive again, and I'm going to make my next statement, combining therapies. What about the benefits of putting more than one drug together? And my statement is this. At the present time, there's no evidence that the combination of any drug with a statin results in a better outcome. So, and that's a big statement, and that data comes in the last 2 years. They have looked at combining fibric acids, benzofibrate, and Lipitor together. It didn't result in any better outcome over Lipitor alone. They looked at niacin, specifically looking at the issue. These are patients on simvastatin or Zocor. They had an LDL cholesterol that was ideal, somewhere between 70 and 80, and they added niacin for pure HDL raising, and it didn't work. And the point is, statins work. That's the point. Again, it's hard to prove a benefit beyond the statin in adding these other therapies. The Zetia-Zocor trial is ongoing, 20,000 patients. It had interim endpoints at 3 years and at 75%, and neither of them went, so it wasn't prematurely terminated. That means it didn't do anything bad, but it also means it didn't have a dramatic beneficial effect. But that's the only ongoing trial. Now, understand that that the combination trials were looking at specific populations. Again, what about niacin as adjunctive therapy if my LDL is not at target? No data. I have no data, and I won't have any data. And nobody has looked at that. And so, if you are not achieving your targeted values with drug X or Y, then there is still no evidence about what else to do about that. And what I want to do is get you on a statin, get you on the best statin I can get you it available. And if I can't, then I'll try something else. And I think that's all I wanted to say. Now, we didn't discuss diet. We didn't discuss, and again, there is no question about the epidemiologic relationship between cholesterol and cardiac events. There's also no question that if you become a vegetarian, combined with exercise 30 to 45 minutes a day, combined the so-called Dean-Ornish approach, it works. It works. There are 25 to 30% fewer events in patients who assume the Dean-Ornish lifestyle, which is a combination of vegetarianism, meditation or relaxation therapy, 45 minutes to an hour a day. So again, and you can't do the Ornish and smoke cigarettes still. It doesn't work. I've got guys who have done that. No, that doesn't work. And when we're manipulating risk factors, cholesterol is one risk factor. And again, what we understand about cholesterol is simplistic at best. Beyond that, these molecular mechanisms, the things that cause atherosclerosis, why one person with a normal cholesterol has an event, but another person doesn't. And the whole complexity of HDL cholesterol, where we give patients drugs that raise their HDL cholesterol, but nothing happened, I don't understand that at all. One would not predict, and Pfizer, your multi-billion-dollar drug company, lost about $1 billion on that bet. There are still ongoing trials that look at HDL. Maybe we're raising the wrong kind of HDL cholesterol. The answer is I don't understand. All right. But now you understand why, if you see me, I want you on a statin. Now you understand why, if you see me, I'm trying to manipulate. I'm trying to put myself out of business. That's what I'm trying to do. And there's no question that there are fewer strokes, heart attacks, or deaths than there were 10 or 20 years ago. Mercy Hospital can tell you that. And the reason is secondary prevention. We know there are fewer events in the cath lab. We know there are fewer heart attacks. We know there are fewer revascularizations, and stents are the same thing. Stents reduce the likelihood of, I used to be able to count on 1/3 of my patients coming back and needing another angioplasty. What a great job. I get to do this 2 or 3 times. But now with a stent, it's less than 10%. So everything we do is intended to try and put me out of business. Eventually, molecular biologists and biochemists will put me out of business through some approach that's pharmacologic, and I'm hoping it has to be given with a catheter, maybe. Then, oh yeah, we can prevent atherosclerosis, but we got to do it in the cath lab.